Good afternoon, ma'am, good afternoon, sir, good afternoon, everyone. So, I'll be presenting a case of Mrs. X, 65-year-old, residing in Kulashekaram, who is a homemaker belonging to upper middle class according to modified Kuppuswamy scale, and she is para 1 L1. She presented to the OPD with chief complaints of postmenopausal bleeding for 2 weeks. She was apparently normal 2 weeks back, after which she noticed bleeding per vaginum. There is no history of postcoital bleed or any hormone replacement therapy. She attained menarche at 11 years of age. She had irregular cycles and was diagnosed to have PCOS. She conceived post-infertility treatment, and her last childbirth was 35 years back. She is a known case of diabetes and hypertension for 5 years, and she is on medications. There is no relevant family history. On general examination, she had she was pale. Her BMI was 31.25 kg per meter square, and she was obese. Her blood pressure was 140 by 90 mmHg. There was no significant lymph nodes. On abdominal examination, there was no mass, tenderness or free fluid, and thyroid, breast and spine appeared normal. My summary: a 65 years old, postmenopausal, obese, hypertensive and diabetic woman presented with abnormal menstrual bleeding for the past 2 weeks. My probable diagnosis is endometrial carcinoma.
Not abnormal menstrual bleeding. There is no menstrual bleeding for this age, no? She already attained menopause. So you have to tell the 65-year-old postmenopausal lady, obese, hypertensive and diabetic, now complains of postmenopausal bleeding for the past 2 weeks. Normal, but you cannot take that literal sense, no? Okay. So why do you say that this is endometrial carcinoma? Why do you suspect? You have only differential diagnosis, no?
Yes, ma'am.
You have only different, you cannot say this is surely endometrial carcinoma. But there are lot of points to suspect endometrial carcinoma. What are the points?
I suspect endometrial carcinoma here because she is obese, she is hypertensive, and she is also diabetic. So, postmenopausal bleeding, her main complaint. Then her age, 65 years.
Any other risk factor in her history?
Yes, ma'am.
Yes, what is that?
She had a history of PCOS. Okay. So, and she has, her menarche was at 11 years, and prolonged estrogen exposure.
Menopause was at what time? Menopause?
Ma'am?
Menopause at what age?
Menopause at 54.
What is the, nowadays, what is the age of, average age of menopause in India?
50.
It has gone up little bit.
55.
Now it is 52, I think. Previously it was 49, now it is 52. So it is a little bit late menopause, no? Okay. So there are some risk factors in this patient to suspect endometrial carcinoma.
Yes,
so can you get endometrial carcinoma in younger ladies?
Yes, ma'am.
Never get? Only after 60s you get?
Yes, ma'am.
What are the two conditions anybody can tell where you get CA endometrium in a younger age group?
Ma'am, familial history, Lynch 2 syndrome.
Yes. Family history, genetic predisposition, genetic mutation. What genetic mutation?
P10, K.
No, that is different. Lynch 2 hereditary non-polyposis colorectal cancer syndrome. Lynch 2 syndrome and PCOS, no? PCOS, not neglected PCOS. That I should say that. They never go to a doctor and always exposed to the high estrogen, never get progesterone in their body, no? So hyperplasia will happen and they go for
C Cowden syndrome.
Cowden syndrome also. Okay. So what are the other type of presentation? Is this CA endometrium always present with postmenopausal bleeding?
No, ma'am. She can also present with discharge.
Yes. Abnormal discharge per vagina.
Yeah, ma'am. in some cases there can also be hypochondriac pain, right hypochondriac pain.
Right hypochondrial pain, why?
Simpson's pain.
Okay, I am not very sure about the lower abdominal pain and lower abdominal lump, menstrual, not menstrual, urinary and bowel symptoms, discharge PV. What is the discharge? Suppose you get a PEARLIN discharge per vagina with a CA endometrium. What is that called? What is that called?
Pyometra.
Collection of pus.
Infection.
So whenever you get pyometra, the collection of pus in the uterine cavity, there are three reasons you have to remember. CA cervix, CA endometrium and one innocent condition also. What is that? Senile endometritis. Where there is due to estrogen deficiency, sometimes they get get infected like that. Senile endometritis. Okay. Okay, then so how will you proceed with this patient?
Ma'am, I will do transvaginal sonography.
You have to complete the clinical. Yes. You have to complete your clinical examination, even if you are.
Yes, ma'am. I will do upper speculum and upper vaginal examination.
Per speculum examination, what all things you have to inspect first the vagina, cervix and two things, vulva, vagina, cervix you have to inspect.
Yes, ma'am.
Anything special in the vagina you look for? Suppose it is estrogen producing tumor.
Dry.
Yes, it will be rugose and pinkish and any suburethral nodules, very rarely you can get. Then cervix, you have to look for any lesions. It can extend to the cervix, no? You don't know the stage and all. So cervix should be seen properly. Then you have to take a pap smear anyway. Then you will do bimanual pelvic examination. So I tell you that in this case, the uterus is only 6 to 8 week size, not palpable per abdomen as you said.
Yes, ma'am.
And it's firm to hard in consistency, mobility a little bit restricted.
Yes, ma'am.
And it is not tender. That is the finding in this case. Okay, then how will you proceed? Is it necessary that uterus should be enlarged in CA endometrium? Because there is a growth, not necessarily, no? An atrophic uterus also can harbor a CA endometrium inside. Only just endometrial thickening may be there, no? Okay, so how will you proceed? Further.
Transvaginal sonography.
You don't do PR? A per-rectal examination is mandatory in all gynecological cases. First orifice, second orifice, no? Because sometimes there can be associated CA, colon, rectum, hemorrhoid, secondary and all, no? So some information you get and the extent of parametrial involvement is excellently palpable only by a PR. When you do PV, the lateral fornix will limit your palpation of the uterosacral and Meccan rods. But when you do PR, you can palpate from the center up to the pelvic wall. Nothing to limit your fingers. So that is why PR is a must in case of to assess the parametrial. And a central mass can be easily evaluated by doing PR, no? A central pelvic mass. Okay. So PR also, in this case, nothing special. Okay. Now you can talk about your ultrasound. No? Everybody is jumping into the imaging. No? That is it. Okay, ultrasound, what are the probable? Which ultrasound you do first?
Transvaginal.
Transvaginal first. Always transabdominal first. Then only you go for a transvaginal. Okay. So, what are the possible findings?
Endometrial thickening, ma'am. If it is more than...
What is the cutoff in a postmenopausal lady?
4 mm.
4 mm. So, if it is more than 4 mm, you will suspect.
Yes,
okay. Then
I will go for endometrial biopsy.
No, what other things in the ultrasound? Only endometrial thickening. Suppose endometrium cannot be delineated, that is also not very good. A growth can be there or polypoidal mass, thickening, altogether it will be a thickened myometrium also can be there. Endomyometrial junction may be blurred. Sometimes collection may be there inside the uterine cavity. And vascularity will be more when you put in the Doppler mode. Okay? Then you have to look at the adnexae and other organs in the abdomen. There is not only the uterus now. So when you do transabdominal, everything should be seen. Then you can you delineate lymph nodes in ultrasound?
No.
No, you cannot. For that you need higher imaging. Okay. So this much you have done. ultrasound you finished. Now you have to confirm your diagnosis. How will you confirm?
I'll do endometrial biopsy. I'll check if there is malignancy.
Endometrial sampling you have to do.
Yes.
Okay. So by the way, you for MBBS. What are the other causes of postmenopausal bleeding? That is a usual.
CA cervix, ma'am.
Yes.
CA cervix, fibroids.
You just imagine the anatomy starting from the vulva to the ovary, no?
Yes, ma'am. Atypical endometrial hyperplasia.
Yes.
Endometritis. TB endometritis. Polyp.
That is the most common, I think, polyps, no? Yes.
That also can cause bleeding. It may not be a cancer alone. Okay. Just a question to the postgraduates. In the ultrasound, one patient is having a thick endometrium. In the other patient, there is a polyp. Okay. What is the next line of management? For both. Better if you find a polyp, actually go for hysteroscopy directly. Because sampling you may not get anything. Go for hysteroscopy, get the polyp. Other one you can do a endometrial sampling. Okay. If you are still doubtful about that, suppose if it's an endometrial CA and you do hysteroscopy, is it good or bad? It's bad, no? Because all these cells are going to go through the fallopian tubes into the peritoneal cavity. Yeah, it will all spread, right? So in that case, if you have any doubt, if you can do an MRI, then you decide. Okay.
So basically what we mean is the method of endometrial sampling depends upon your ultrasound finding. Suppose the uterine cavity is filled with a big mass, it will be difficult to go ahead with an hysteroscopy and all, no? And you doubt about spread and all. You are very sure about it is the endometrium. In that case, you can directly go for a sampling. But Pipple sampling, have you heard about Pipple sampling? Yeah. The sensitivity is very good, no? 97%. Okay. So what is the usual histopathology you get? What's the usual pathological types?
Ma'am, it can be endometroid.
Endometroid, usually.
Or it is also called as adenocarcinoma. Then serous, mucinous, mixed type, serous papillary can be there, clear cell, carcinosarcoma.
Okay, there are so many, but with a predisposed, prolonged exposure to estrogen and all, it will be type 1, no? Type 1 is usually endometrioid carcinoma. Okay, so now you know that there is endometrioid carcinoma. Now what is your further management? Will you go for any other investigation?
Yes, ma'am.
For management, you have to do blood, all those things, X-ray, chest. Will you do tumor marker?
Yes, ma'am.
Will it helpful for anything? For CA endometrium?
Yes, ma'am.
CA125 is not diagnostic, but for follow-up, some people may use this when it is elevated. Okay. So your next mission will be to treat the patient, no? What is the cornerstone of treatment? Before treatment, you have to stage.
Yes, ma'am.
How will you stage the disease?
Ma'am, by with endometrial biopsy.
Endometrial biopsy done and it is CA.
Yes, ma'am.
Now what imaging you will do, and after that only you will do laparotomy, no? So higher imaging is required.
MRI.
MRI is required to know the extent of the disease and lymph node involvement, upper abdominal disease, and you should read the 2023 classic FIGO staging. So a lot of subdivisions are there. And surgical staging is the method of staging. You cannot stage the CA endometrium just by clinically. Only if it is inoperable you can do that. Otherwise, the idea is there is a place for surgery and remove, because you do some removal of the tumor also, no? So there is a role for surgery in all stages of CA endometrium. Okay. So you do surgical staging. You should know the steps of surgical staging and what surgery you will do. Not only staging, no?
Total hysterectomy with bilateral salpingo-oophorectomy.
And
in case of serous type, I can do omentectomy. In case of mucinous, I will do appendectomy.
what about lymphadenectomy?
Lymph nodes also.
Yeah, big tumors with aggressive tumors, you may have to go for lymphadenectomy. If you do lymphadenectomy, you have to go for para-aortic also, because upper part of the uterus is drained into the para-aortic nodes. Okay, then after the surgery, you have to restage. You have to correctly stage the disease after the surgery and histopathological evaluation. No? Then further treatment. Will they need any further treatment?
Yes, ma'am. Radiotherapy, and in case of
it is called adjuvant therapy. No, what?
Yes, ma'am.
You have to categorize. No, risk categorization should be done. Low risk,
High risk.
high risk, intermediate
Yes.
risk, and high intermediate and high risk, and metastatic. And the further treatment will depend upon the risk. Understand? Risk depends upon stage, grade, what else? Type, stage, grade, and molecular genetics. Nowadays they are doing molecular genetics also of this tumor. So depending upon that lymphovascular invasion, they categorize the risk, and further management is. And the last question I want to ask is, what is meant by sentinel node mapping? Have you heard about that? Postgraduates? Sentinel node mapping?
First node to be involved.
Before laparotomy, you inject indocyanine into the cervix, and when you open, you look the stained lymph nodes and sample it. Frozen should be there, and if it is not involved, there is no need to proceed with the lymphadenectomy. And if there is involvement, only you proceed with the systematic lymphadenectomy, and also to plan further treatment. In a low risk case, otherwise adjuvant treatment is not required, but if the lymph nodes are involved, you may have to go for adjuvant treatment. Okay, so time is over now. Yes. So what is the message you are getting by presenting this case? A postmenopausal bleeding patient can be a malignancy as well as a senile endometritis, or it can be anything. So you have to properly evaluate very basically, history, examination, inspection, then ultrasound, and it cannot be taken from, as the years passes from the menopause, the chances of being malignancy is more. Soon after menopausal bleeding may be not that dangerous, but as the years pass on, the chance of malignancy is more. But benign conditions are also there, and hysteroscopy is the gold standard. Hysteroscopic biopsy is the gold standard evaluation of these cases for sampling. Okay.
Follow for what? See, just be practical, don't go by books. Yeah, see, you have taken biopsy from somewhere. You have not seen the inside of the cavity. You have scraped from somewhere. That place has come as hyperplasia. You have no idea about the other places where you have not scraped. Why to take a chance? Okay, just be practical. You tell them. The patient might be like, I don't want my uterus to be out. She wants to retain it. But you tell them, see, this is hyperplastic. There is no point in keeping it there. Counsel them, do hysterectomy. Okay, this is just a practical approach, not book-wise.
When you get the entire uterus out only, you can definitely rule out, no?